There is something happening inside your brain right now. A cleaning cycle. And most people have never heard of it. Every night, while you sleep, your brain runs a kind of biological maintenance shift. It flushes out toxic waste. It clears the proteins that, if left to accumulate, become the building blocks of Alzheimer's disease. But here is what most people don't know. This system is gravity dependent. The position your body is in while you sleep directly affects how well that cleaning cycle runs. And researchers have now found that spending just 2 hours per night in the wrong position may be enough to interfere with it in a meaningful way. In the next 40 minutes, I am going to walk you through the biology behind this. What your brain is actually doing at night, which positions block that process and why, and exactly what to do instead. This is not about comfort. This is about what happens to your brain over years of sleeping in a position that quietly works against it. Let me start with the biology, because once you understand what is happening inside your brain at night, everything else in this conversation will make more sense. Think of your brain as a busy city. During the day, that city is running at full capacity. Traffic, construction, energy use. And just like any city, all of that activity produces waste, metabolic byproducts, cellular debris, proteins that build up as a natural result of your neurons doing their job. Now, your body has a system for clearing that waste. In the rest of your body, it is the lymphatic system, a network of vessels that drains cellular waste and carries it away. But the brain is sealed off behind something called the blood-brain barrier, so it cannot use that same network directly. What it uses instead was only discovered within the last 15 years or so. Scientists at the University of Rochester identified what they now call the glymphatic system. Think of it as the brain's own private sanitation crew, a night shift cleaning operation that runs almost exclusively while you sleep. Here is how it works. During deep sleep, the cells in your brain actually shrink. They physically reduce in size by roughly 60%. And when they do that, they open up channels, narrow spaces between cells, that allow cerebrospinal fluid to flow through the brain tissue. That fluid acts like a rinse cycle. It moves through those channels, picks up the waste products that accumulated during the day, and carries them out of the brain. The two most important waste products it is clearing are proteins called amyloid beta and tau. You may have heard those names before. Amyloid beta plaques and tau tangles are the hallmarks of Alzheimer's disease. They do not appear overnight. They accumulate slowly, over years and decades, when the brain's clearing system is not doing its job efficiently. And here is the part that most people, including most doctors, have never stopped to consider. The brain does not care how many hours you spend in bed. It cares about something far more specific. Something that most seniors are unknowingly working against every single night. Now here is where sleep position enters the picture. This glymphatic system is not just dependent on sleep. It is dependent on the specific stage of sleep, slow wave sleep, what most people call deep sleep, and it is also affected by gravity. The flow of cerebrospinal fluid through the brain changes depending on how your body is positioned. Some positions allow that fluid to move more freely. Others restrict it. Some positions make the whole process dramatically less efficient. Researchers at Stony Brook University published a study in the Journal of Neuroscience looking at exactly this. Using contrast imaging in animal models, they were able to observe glymphatic transport in real time across 3 sleeping positions: on the side, on the back, and on the stomach. The lateral position, sleeping on your side, showed the most efficient glymphatic transport. The supine position, flat on the back, showed significantly reduced clearance. Prone, face down, showed the worst. Now, this research was conducted in animal models, and I want to be honest with you about that. Direct MRI imaging of the glymphatic system in living humans during sleep is still an emerging area. But the biological mechanism is well established. The association in human observational studies is strong, and the research community is taking it seriously enough that it was presented at the 2024 Alzheimer's Association International Conference. What that conference data showed, drawn from home sleep monitoring across hundreds of participants, is that people with neurodegenerative diseases, including Alzheimer's and Parkinson's, spent significantly more time on their backs than healthy controls. And there was a specific threshold that appeared consistently across the data, one that most back sleepers are unknowingly crossing every single night. I will get to that number in a moment, but first, you need to understand exactly why that position is so damaging at the level of biology. So before we talk about what to do, we need to understand what gets in the way. And the first place to look is the position most people assume is completely harmless. Let's talk about back sleeping first, because it is the most studied position in this context, and it is also the most common default for seniors. There are good reasons people end up on their backs. If you have reflux, lying flat on your side can feel uncomfortable. If you have hip pain or arthritis, the back can feel like the path of least resistance. And for decades, back sleeping carried a reputation as the correct position: straight spine, even weight distribution, no pressure on the joints. Many people were told by doctors or physical therapists to sleep on their backs. So they did. But here is what that conventional wisdom missed entirely. It did not account for what happens inside the brain when you are in that position. And now that we understand the glymphatic system, the picture changes. When you lie flat on your back, several things happen at once. Venous blood return, the flow of blood back toward the heart from the head, is altered. The drainage pathways for cerebrospinal fluid become less efficient. And the net effect is that the brain's cleaning cycle slows down. Think of it like a garden hose. When the hose is open and lying flat, water flows freely from one end to the other. Now kink that hose or reduce the pressure at the source, and the flow slows to a trickle. The hose still exists. The water is still there. But the job is not getting done. The 2024 data presented at the Alzheimer's Association International Conference made something very specific clear. It was not just that back sleeping was associated with neurodegenerative disease, it was the duration. More than 2 hours per night in the supine position was the threshold that consistently appeared across the data. Not all night, not even half the night. 2 hours. That is a number that should give us pause, because most seniors who default to back sleeping are spending far more than 2 hours in that position without knowing it. And here is where it gets compounded. There is a second mechanism, separate from the fluid dynamics, that makes back sleeping significantly more damaging for a large subset of seniors. I will explain exactly what that is when we get to the sleep apnea section. But for now, understand that what you are about to read about fluid flow is only part of the picture. I see this pattern in my clinic regularly, and what I have noticed, something that took me years to fully appreciate, is that the patients who make one very specific adjustment to their sleep setup show a different trajectory than those who only change their position. It is a single step that most people skip entirely, and skipping it is the reason side sleeping fails for so many people who have tried it before. I will show you exactly what that adjustment is before this video ends. But first, you need to understand the full picture of what is going wrong. A patient comes in with complaints of memory fog, difficulty finding words, waking up feeling unrefreshed no matter how many hours they spent in bed. We review their sleep history. We look at their sleep tracker data when they have it, and often, not always, but often, there is a consistent pattern of prolonged time on their back, combined with some degree of undiagnosed or undertreated sleep apnea. Neither one alone is catastrophic. Together, they create the conditions for years of suboptimal brain clearance. One patient in particular stays with me. A retired school teacher in her early 70s, bright, active, engaged. She came in concerned about what she described as a new kind of fogginess. Not dramatic, not the sudden changes that would signal a stroke, just a slow dimming that she noticed in herself. Her sleep tracker showed she was spending the majority of the night on her back. She had been told years ago that it was the best position for her lower back issues. Nobody had ever connected her sleeping position to her brain health. We moved her to a supported side-lying position with a pillow between her knees and a properly sized head pillow to keep her neck neutral. Within several weeks, she reported that the fog had noticeably lifted. Now, back sleeping is the most well-documented risk in this context. But there is a second position that creates its own distinct set of problems, and most people who do it have never once considered stopping. Most people who sleep on their stomachs have been doing it their entire lives. It is one of those habits that starts in childhood and just never gets questioned. And when I bring it up in my clinic, the response is almost always the same. But it's the only position I can actually fall asleep in. I understand that. Old habits in sleep are some of the most deeply wired behaviors we have. But I want you to understand what is happening in your body during those hours, because stomach sleeping creates a specific set of problems that go well beyond comfort. The most immediate issue is what happens to your neck. When you sleep face down, you have to rotate your head to one side to breathe. There is no other option. And that rotation, held for hours in the same direction night after night, puts the cervical spine into a sustained, unnatural twist. The muscles along the neck tighten to compensate. The vertebrae are compressed unevenly. Over time, this accelerates wear on the cervical discs, which is a real concern for anyone already managing arthritis or any degree of spinal degeneration. But what concerns me most from a neurological standpoint is what that rotation does to the vertebral arteries. These are the arteries that run up through the vertebrae in your neck and supply blood directly to the brainstem and cerebellum. When the neck is rotated significantly, and stomach sleeping typically involves rotation well beyond 45 degrees, those arteries can be partially compressed. Partially. Not blocked entirely, but narrowed enough that blood flow to the brainstem is reduced during the exact window when your brain is supposed to be running its cleaning cycle. Think of it this way. Imagine a long electrical cord plugged into the wall. If you pull the plug halfway out, the lamp at the end of the cord starts to flicker. The connection is still there, but the signal is weaker the further it travels. That is what happens with reduced vertebral artery flow during stomach sleeping. The brain is not being starved, but it is being subtly underserved. Less oxygen delivery, less efficient circulation during the hours when it needs the most support. There is another dimension to this that rarely gets discussed. The diaphragm is compressed when you sleep face down. Your body weight is pressing directly onto your chest and abdomen, which restricts how fully your lungs can expand with each breath. This leads to shallower breathing throughout the night. Less oxygen in with each breath means less oxygen circulating in the blood. And less oxygen in the blood means less reaching the brain at the precise time the glymphatic system is doing its most critical work. The symptoms of this pattern are things many seniors have simply accepted as part of getting older. Waking up with neck stiffness that takes an hour to resolve. Tingling or numbness in the hands or fingers. Morning headaches that seem to fade once you are up and moving. A persistent, low-grade fogginess in the first part of the day. These are not just aging, they are signals. Your body is telling you something about how it spent the night. The spine also pays a long-term price. Stomach sleeping places the lumbar spine into an extended, arched position for hours at a time. For seniors already managing disc issues or spinal stenosis, this is adding insult to injury, compressing structures that need space and relief, not sustained pressure. I am not going to tell you that changing a lifelong sleep habit is easy. It is not. But the cost of not changing it is worth understanding clearly. And there is a third position we need to discuss, one that millions of seniors have turned to specifically because it feels like the right answer. That instinct is understandable. But what is actually happening during those hours tells a very different story. The recliner is one of those pieces of furniture that feels like a gift. For seniors managing acid reflux, chronic back pain, or difficulty breathing when lying flat, it seems like the logical answer. And so, gradually, it stops being a chair for watching television. It becomes the place where sleep happens. Night after night, for months. Sometimes for years. I understand the appeal. When lying flat causes pain or burning or breathlessness, the body searches for relief. The recliner provides it, or at least something that feels like it. But comfortable and restorative are not the same thing. And in the case of recliner sleeping, the gap between those two is significant. The semi-upright angle, typically between 40 and 70 degrees, prevents the body from cycling normally through its sleep stages. Deep, slow-wave sleep, the stage where the glymphatic system is most active, requires core temperature to drop, muscle tension to fully release, and the cardiovascular system to shift into a specific resting pattern. The recliner works against all of these. The body is partially upright, which means it is partially alert. Muscle tension in the neck, shoulders, and hips stays elevated all night. You can spend 8 hours in a recliner and never reach the depth of sleep your brain needs to do its cleaning work. You are resting. You are not restoring. Now add what happens below the waist. In a reclined position, blood pools in the lower legs. Without the full horizontal position to assist venous return, fluid accumulates in the legs and ankles, which is why many recliner sleepers wake with swelling. But the downstream effect matters more than the visible symptom. Blood pooling in the legs means less oxygenated blood reaching the brain during the exact hours when it needs the most circulatory support. The spine also pays a price. A true horizontal position allows the intervertebral discs to rehydrate and the paraspinal muscles to fully release the load they have been carrying all day. In a recliner, that decompression never fully happens, which is why people wake stiff and sore even after what felt like a full night of rest. If reflux or breathing discomfort is what drove you to the recliner, the answer is not to give up on elevation. It is to get the right kind. A wedge pillow that lifts the entire upper body at 15 to 30 degrees while you remain in a side-lying position addresses both reflux and breathing without sacrificing the deep sleep stages the glymphatic system depends on. That is the distinction that changes everything. and it is exactly what we will cover in the setup protocol ahead. So let's talk about what actually works. Because after everything we have covered, the glymphatic system, the 2-hour threshold, the specific ways that back sleeping and stomach sleeping and recliner sleeping each undermine the brain's cleaning cycle, the natural question is, what should I be doing instead? The answer, based on the current weight of research, is side sleeping. And I want to be direct about that rather than hedge it with unnecessary qualifications. Side sleeping is the most well-supported position for glymphatic clearance. That is not a fringe opinion. It is the conclusion that emerges consistently from the imaging studies, the observational data, and the biological reasoning about how cerebrospinal fluid moves through the brain. Let me explain why it works at the level of mechanics. When you lie on your side, gravity assists the flow of cerebrospinal fluid through the perivascular spaces, the narrow channels that run alongside the blood vessels in the brain. These channels are the pathways the glymphatic system uses to flush waste. In the lateral position, the geometry of those pathways, combined with gravity, allows fluid to move more freely in the direction it needs to move. The Stony Brook imaging studies showed the highest rates of CSF and interstitial fluid exchange occurring in the lateral position. This is not a subtle difference. It is a meaningful one. Now I want to address something directly because I hear this question often. Left side or right side? Does it matter? Here is the honest answer. Both sides are substantially better than back sleeping or stomach sleeping when it comes to glymphatic function. The lateral position itself is the primary variable. That said, there are secondary reasons to favor the left side when possible. Left side sleeping takes pressure off the inferior vena cava, the large vein that returns blood from the lower body to the heart, which supports more efficient cardiovascular circulation through the night. There is also a reflux benefit. Left side sleeping keeps the junction between the stomach and esophagus above the level of stomach acid, which is why it is often more effective for nighttime reflux than any medication adjustment. Right side sleeping is also beneficial and is meaningfully better than supine or prone sleeping. For people who have certain shoulder conditions or rotator cuff issues on the left side, sleeping on the right is a completely reasonable primary position. The goal is lateral. Which side is a secondary consideration? Now, I know what some of you are already thinking, because I hear it in my clinic almost every time this conversation comes up. I've tried sleeping on my side, my hip hurts, my shoulder goes numb. I always end up rolling onto my back by morning. These are real barriers. They are not excuses. They are physical realities that deserve real solutions. And I want to be clear that the failure of previous attempts at side sleeping is almost never a problem with the position itself. It is a problem with the setup. Side sleeping done incorrectly puts the hip under direct compressive load, collapses the neck into lateral flexion, and jams the bottom shoulder into an uncomfortable position that wakes you within hours. Side sleeping done correctly does none of those things. The difference between those two experiences is almost entirely about pillow placement and a few small positional adjustments that cost nothing and take about 60 seconds to set up. There is also the honest reality that no one stays in one position all night. We shift naturally during sleep, and that is normal. The goal is not to be rigid. The goal is to start in the right position, create conditions that make it easy for the body to return to that position after shifting, and reduce the structural barriers that cause you to abandon it in the middle of the night. In my neurology clinic, I have watched patients make this one change, moving from habitual back sleeping to supported side sleeping, and report improvements in morning alertness, reduced cognitive fog, and better overall sleep quality within weeks. The brain is remarkably resilient. Give it the conditions it needs, and it responds. The position is the foundation. But what most people miss, and what determines whether side sleeping actually holds up through the night, comes down to a few small adjustments that most people never make. Let me walk you through this step by step. Because the difference between side sleeping that works and side sleeping that fails almost always comes down to a few specific adjustments. None of them require expensive equipment. All of them can be implemented tonight. The single most impactful change you can make is placing a pillow between your knees. This one adjustment does more than almost anything else to make side sleeping sustainable, and it is also the step most people skip, which is why they abandon the position by 3 in the morning and wake up on their back wondering why it did not work. Here is why it matters so much. When you lie on your side without support between your knees, the top leg naturally drops forward and downward with gravity. That rotation pulls the hip out of alignment, which creates a torquing force through the lower back and sacroiliac joint. Over the course of a night, that sustained twist produces the kind of hip and lower back ache that makes people conclude side sleeping is simply not for them. The problem was never the position. It was the missing support. A pillow between the knees keeps the pelvis level, prevents that forward rotation of the top hip, and removes the mechanical strain entirely. Not a thick pillow, not a decorative throw pillow. A medium firmness pillow, roughly the width of your knee to ankle distance, works best. Some people prefer a contoured knee pillow designed specifically for this purpose, but an ordinary bed pillow folded once achieves the same result. The second adjustment is your head pillow. This is where most side sleepers create problems without realizing it. The purpose of the head pillow in a side-lying position is to fill the gap between your ear and the mattress, nothing more, nothing less. Too flat, and your neck collapses downward into lateral flexion, which strains the muscles along the side of the neck and compresses the cervical vertebrae unevenly. Too high, and your neck is pushed upward and away from the mattress, creating the opposite problem. What you want is a neutral spine, your ear, shoulder, and hip in a straight line when someone views you from behind. A contoured memory foam pillow designed for side sleeping accomplishes this for most people. If you are using a standard pillow, pay attention to how it feels after 30 minutes in position. If your neck feels strained in any direction, the height is off. The third adjustment is shoulder positioning, and this is the one most people overlook. When you lie on your side, the bottom shoulder should not be directly underneath your body. It should be slightly forward, perhaps 2 to 3 inches in front of the midline of your torso. This prevents the shoulder joint from bearing the full compressive load of your body weight, which is what causes the deep shoulder ache and numbness that many side sleepers experience. You can achieve this by slightly shrugging the bottom shoulder forward as you settle into position. Your arm can rest comfortably in front of you rather than trapped beneath your body. For those dealing with hip arthritis or greater trochanteric bursitis, direct pressure on the hip bone against the mattress is a real and legitimate barrier. 2 practical solutions here. First, a mattress topper with some give, even a 2-inch foam topper, distributes that contact pressure more broadly and can make a significant difference. Second, sleeping on the less affected side when possible reduces the load on the more inflamed hip. If both hips are symptomatic, a softer sleeping surface at the hip contact point, combined with the knee pillow, is usually enough to make the position workable. Finally, and this is particularly useful for habitual back sleepers who are trying to transition, a body pillow placed behind your back after you settle into the side-lying position is a simple and highly effective way to prevent rolling onto your back during the night. You do not need to hug it. Just place it along your spine as a physical cue. Your body will register the resistance and stop rolling. Over several weeks, the lateral position becomes the new default, and the pillow becomes less necessary. These adjustments take less than a minute to set up, but they are the difference between a position that feels punishing by 3 in the morning and one your body actually stays in. There is one more layer to this conversation that I cannot leave out, because even if you make every positional change we have discussed, even if you transition fully to supported side sleeping with the knee pillow, the correct head support, the shoulder adjustment, there is a condition that quietly undermines all of it, and it is present in a significant portion of the seniors sitting with this video right now, most of them without knowing it. That condition is sleep apnea. Conservative estimates suggest that at least 20% of adults over 65 have obstructive sleep apnea. The real number is almost certainly higher because it is one of the most underdiagnosed conditions in older adults. The symptoms overlap almost perfectly with what most people attribute to normal aging. Daytime fatigue, difficulty concentrating, waking up feeling unrefreshed, a kind of low-grade mental fog that never fully clears. Most seniors accept these as the expected cost of getting older. Their doctors sometimes do too, and so the apnea goes undetected for years. Here is why this matters so directly for the glymphatic system, and why I flagged it earlier as the compounding factor that makes back sleeping more dangerous than most people realize. Sleep apnea works by fragmenting sleep. Every time an apnea event occurs, every time the airway collapses and breathing pauses, the brain registers the oxygen drop and pulls itself out of deep sleep to restore normal breathing. These arousals can happen dozens of times per hour. The person experiencing them rarely wakes up fully or consciously registers the interruption. But the architecture of their sleep is being shattered night after night. The deep, slow-wave stages, the ones where the glymphatic system runs at full capacity, are being interrupted constantly. It is like trying to run a cleaning crew through a building while someone keeps tripping the circuit breaker every few minutes. The crew never gets to finish the job, and the positional connection is what makes this a two-pronged problem. Supine sleeping dramatically worsens apnea severity. When you lie flat on your back, the tongue and the soft tissues of the throat fall backward with gravity and narrow the airway. This is why so many apnea sufferers are positional. Their apnea is mild to moderate when on their side, and significantly worse on their back. So back sleeping reduces glymphatic clearance directly through the mechanics of fluid flow, and simultaneously worsens the apnea that destroys the deep sleep stages that clearance depends on. One position, two mechanisms, working against the brain at the same time. A landmark UCSF study followed elderly women with sleep-disordered breathing over 5 years and found that those with significant oxygen desaturation during sleep were nearly twice as likely to develop dementia or mild cognitive impairment compared to those without it. The key driver was not the number of arousals, it was the hypoxia, the oxygen deprivation itself. Every time oxygen drops during an apnea event, the brain is being undersupplied during a window when it should be receiving full circulatory support for its cleaning and repair work. The symptoms worth paying attention to are waking unrefreshed even after a full night of sleep, morning headaches that resolve within an hour of getting up, a partner reporting pauses in your breathing or unusually loud snoring, and unexplained cognitive fog that has been gradually worsening. Any of these warrant a conversation with your physician and potentially a sleep study. A home sleep test is now available through most primary care practices and does not require an overnight stay in a lab. For a meaningful subset of seniors, positional therapy alone, simply moving from back sleeping to side sleeping, reduces apnea severity enough to make a measurable difference. Side sleeping keeps the airway more open, reduces the frequency of obstructive events, and protects the deep sleep architecture the glymphatic system depends on. It is not a replacement for CPAP in moderate to severe cases, but it is a meaningful first intervention, and knowing it exists changes what you do tonight, which is exactly where we are going next. So let's bring everything together, because understanding what harms the brain is only half the work. The other half is knowing exactly what to do tonight in a specific and practical way. Think of what I am about to walk you through as a closing routine for your brain. The same way you might have a morning routine that sets you up for the day, the 30 minutes before sleep can either support or undermine everything your brain is trying to accomplish overnight. Small choices, real consequences. Step 1 is position setup. Start on your left side when possible. Pillow between the knees, positioned to keep the pelvis level. Head pillow filling the gap between your ear and the mattress, not compressing your neck downward, not pushing it upward. Bottom shoulder slightly forward, so the joint is not bearing your full body weight. If you are a habitual back sleeper making this transition, place a body pillow behind your spine before you close your eyes. It does not need to be expensive. A regular bed pillow works. The goal is a physical cue that interrupts the rolling pattern your body has been following for years. Step 2 applies to those of you dealing with reflux, breathing difficulty, or any condition that makes lying fully flat uncomfortable. The solution is not a recliner. The solution is a wedge pillow that elevates the entire upper body from the hips upward at roughly 15 to 30 degrees while you remain in a side-lying position. In the left side position specifically, this elevation also keeps the junction between the stomach and esophagus above the level of stomach acid, which is why left side sleeping with a wedge is often more effective for reflux than any other sleep setup. The key distinction is that the incline lifts your whole torso, not just your head. Stacking pillows under your head alone creates neck flexion problems and does not provide the reflux relief a proper wedge does. Step 3 is temperature. Your bedroom should be cool. Between 65 and 68 degrees Fahrenheit is the range that most consistently supports deep, slow-wave sleep. Here is why this matters directly. The drop in core body temperature that happens as you fall asleep is one of the primary triggers that pulls the brain into the deep sleep stages where the glymphatic system runs at peak efficiency. A warm room delays and suppresses that temperature drop. A cool room supports it. This is one of the least discussed and most impactful environmental adjustments available to you, and it costs nothing beyond adjusting a thermostat. Step 4 is screen cutoff. Blue light from phones, tablets, and television suppresses melatonin production and delays the onset of slow-wave sleep. Not by minutes, by a meaningful portion of your sleep cycle. 45 to 60 minutes of screen-free wind-down before bed allows melatonin to rise naturally, sleep onset to happen at the right time, and the brain to move through its architecture in the sequence it was designed to follow. Reading, quiet conversation, gentle stretching, anything that does not involve a backlit screen in the final hour before sleep. Step 5 is hydration timing. Most people never connect this to brain health, but mild dehydration thickens cerebrospinal fluid and directly impairs glymphatic flow. The brain's cleaning cycle requires adequate fluid to move efficiently through those perivascular channels. But the solution is not drinking heavily before bed. That creates disruptive nighttime waking that fragments the deep sleep you are trying to protect. The answer is adequate hydration throughout the day, tapering off about 90 minutes before bed. A small glass of water with any evening medications is fine. The goal is arriving at sleep well hydrated without setting up a bathroom trip at 2 in the morning. None of this requires a prescription. None of it requires a referral. These are zero-cost interventions that align your sleep environment with the biology your brain is trying to run. And I want to be honest with you about something. No single night of optimal sleep undoes years of suboptimal sleep. That is not how this works. But the glymphatic system does not stop functioning with age. It becomes less efficient. And efficiency responds to conditions. Give the system better conditions consistently, and it responds. The brain is more resilient than most people believe. Which brings me to the most important thing I want you to leave this conversation understanding. I want to address something directly, because I hear a version of this question in my clinic more than almost any other. Patients sit across from me and ask, in different ways, the same thing. Is it already too late? They have spent years sleeping on their back, or in a recliner, or face down on a stomach that has been twisted to the left since 1987. And now they are learning that those years may have quietly worked against their brain's ability to clean itself. So they want to know whether any of this still matters, whether the changes we have discussed can actually make a difference at this point. The answer is yes, and I do not say that to comfort you. I say it because the neuroscience supports it. Neuroplasticity, the brain's capacity to form new connections and reorganize its own pathways, continues into the 7th and 8th decades of life. The glymphatic system does not shut down with age. It slows. It becomes less efficient. But it remains responsive to the conditions you create for it. Better sleep position, better deep sleep, better clearance. The system is still there. It still wants to do its job. What you are doing when you make these changes is removing the obstacles that have been working against it. The DTI-ALPS research, a non-invasive MRI measure of glymphatic function, has shown that glymphatic activity mediates a meaningful and measurable portion of the age-related effect on cognitive decline. Over 20%. That is not a marginal number. That is a significant, modifiable share of a process that most people have been told is simply inevitable. Cognitive reserve matters here too. Your brain's ability to improvise and find alternate pathways around damage is built through engagement, learning, movement, and sleep. Sleep is not optional in that equation. It is foundational. Every night of genuinely restorative, lateral, deep sleep is a deposit into that reserve. I have watched patients in their early 70s come in convinced that their memory lapses were the beginning of a permanent decline. After addressing sleep position, treating undiagnosed apnea, and improving sleep hygiene, their subjective cognitive complaints improved substantially over months. Not because we reversed disease, but because we stopped adding to the burden and gave the brain what it needed to do its own work. I will not overstate what sleep position alone can do. There is no single intervention that prevents dementia. The biology is complex and multifactorial. But sleeping position is one of the most accessible, zero-cost levers available to you. The biology supports using it, and the cost of not using it, accumulated across years of interrupted glymphatic clearance, is real. Your brain is remarkable. It has been doing its job under conditions that were working against it, and it has kept going. Give it better conditions. Tonight, and then keep going. Because what happens while you sleep is only one half of the picture. What you put into your body in the hours before sleep determines whether the glymphatic system has what it needs to actually finish the job. There is something I need to tell you before you close this video. And I want you to hear it the way I would say it to a patient sitting across from me. Everything you just learned, the lateral position, the knee pillow, the shoulder adjustment, the wedge for reflux, all of it creates a window. A window in which your brain can finally run its cleaning cycle the way it is supposed to. That is real. That matters. But that window can be closed by something most seniors do every single morning without thinking twice. There is a breakfast food, something commonly served at kitchen tables across the country, something many doctors still recommend, that raises inflammation in the brain and directly disrupts the same glymphatic pathways you just spent 40 minutes learning to protect. It does not matter how well you slept if you sit down to this in the morning. The clearance work the brain just completed gets undermined within the first hour of the day. I have a video on exactly this, and it is on your screen right now. I want to be straightforward with you. If you care about what you just learned, that video is not optional. It is the next step. Sleep position and morning nutrition are two sides of the same system. Fixing one without understanding the other leaves the work unfinished. Click the video on your screen now. I will meet you there.